Thank you all so much for being here today. We want to welcome you to this event sponsored by the Health Law and Policy Program. Here at WCL, the pursuit of equity inspires our dedication to health law, and we are very pleased to be in the second year of this Future of Healthcare series, which reaches a broad and diverse national audience across sectors. So these panel discussions as part of the series examines trends, challenges, and opportunities in healthcare and the role of law and policy in shaping our healthcare system. And with the series, we try to highlight both practitioner and scholar perspectives on a wide range of timely topics. We want to give our deepest thanks to our terrific partners, the American Health Law Association and the American Society of Law, Medicine, and Ethics. The American Health Law Association is the nation's largest nonpartisan 501c3 educational organization devoted to legal issues in the healthcare field. And this association maintains excellence in health law by educating and connecting the health law community. The American Society of Law, Medicine, and Ethics is a nonprofit educational organization whose mission is to provide high-quality scholarship, debate, and critical thought for professionals at the intersection of law, medicine, and ethics. This event is also being live streamed on Zoom. Please note that live captioning is available through Zoom. This event is also being recorded and it will be available on our Future of Healthcare website. So before we begin with our panelists, it's my pleasure to introduce Dean Roger Fairfax, who will provide some brief welcome remarks. Dean Fairfax is a prominent legal scholar, educator, and nationally known expert on criminal justice. He has taught courses and conducted research on criminal law and procedure, professional responsibility and ethics, criminal justice policy and reform, racial justice, and grand jury and internal investigations. And in addition, he is a dedicated champion of diversity, equity, and inclusion efforts throughout higher education and the legal profession. And we are so grateful for his support of the Health Law and Policy Program. Thank you so much, Steve.
Thank you, Maya, for that kind introduction. Good afternoon. I have my friends from Ohio State and from GW visiting with us. I want you to show them how WCL does it. Good afternoon. Good afternoon. WCL welcome. It is great to be here. I am thrilled to be able to give these welcome remarks and to help to introduce the latest in our series, The Future of Healthcare, Genomics, AI, and the African Diaspora. Now, I remember welcoming guests to the launch of this series, and I'm thrilled to see how much of an impact the future of healthcare has had on health law and policy. And as I said during that launch, I'm so proud of our nationally recognized health law and policy program, led by faculty director Maya Mannion and director Asha Shelza, who's around here somewhere, and along with a strong team of faculty and staff. And our faculty are experts across a number of health law domains, including reproductive health and food and drug and compliance and fraud and abuse and bioethics and patents and decision-making around reproduction with an emphasis on health equity. And the healthcare field certainly is dynamic and complex. Technological innovations, cost concerns, growing awareness of racial and socioeconomic disparities, and public health emergencies are changing how healthcare is accessed, delivered, financed, and reimbursed. And health systems are ripe for disruption, and widespread health inequities are a pressing concern. As we all know, health laws promote healthy living conditions and access to quality health care and protect the privacy and safety of patients and research participants and eliminate fraud, waste, and abuse. And our faculty and staff here at WCL are dedicated to training the next generation of health lawyers to tackle these growing challenges. The Future of Healthcare series is but one example of the robust initiatives and curriculum that the Health Law and Policy program offers. And I would like to thank again our tremendous partners, the American Health Law Association and the American Society of Law, Medicine, and Ethics for their support. Now, today's panel discussion, Genomics, AI, and the African Diaspora, considers the way in which modern advances in technology, such as quantum computing and artificial intelligence, will impact research and thus delivery of healthcare, and how that might reflect racial inequities and misunderstandings. Assistant Professor of Law, I usually call him Superstar, but I'll use his official title here. Assistant Professor of Law, Thomas Williams, who's moderating the panel, he focuses his research in part on analysis of health law and bioethics and entrepreneurship, including the mitigation of health inequities and disparities. He teaches a number of courses, including health law and the popular pandemic and popular culture, science narrative and public policy. We are thrilled to have him on our faculty. He has been just a burst of energy in our already well-established Health Law and Policy program. I want to thank him for moderating this panel. With that, I will hand it over to Professor Williams. Thanks so much for being here.
A huge thank you to you, Dean Fairfax, also to the Health Law Policy and Law Program Director, Asha Shelzo, Maya Manian, as well as the staff, Asha Shelzo, recently departed, Tori Nadell, not departed to the other side, simply departed from the institution for creating the infrastructure through which we can have programs like this. Professor Callier, Professor Yearby, thank you so much for being here today. I'm really excited to share with you and talk through some of the questions here. I'll ask you to say a little bit about yourselves, but I'll give a bit of a kickoff. So Professor Callier, you are down the street at GW University School of Medicine, where you are a genetics professor. Can you give us a little color to your research? Because I think you have just a fascinating lens that's going to help guide our conversation today.
Sure, and I actually teach bioethics and health law, but I also do quite a bit of lecturing on genome policy. And so most of my research collaborations are with geneticists. I have an appointment as a special volunteer at the Center for Research on Genomics and Global Health at the National Human Genome Research Institute at NIH and HGRI. And I've held that appointment for about 12 years. And so most of the work I do, I'm looking at bioethics issues, I'm looking at health policy issues, and I'm definitely working with scientists on cutting edge questions in genetics.
That's great. And just for the audience, we're going to talk about ELSI later. Can you just give us a definition of ELSI?
Yes, absolutely. So ELSI is an acronym that stands for the Ethical, Legal, and Social Implications of Genomics. And it is an interdisciplinary field where scholars from sociology, theology, anthropology, law, medicine come together to anticipate the challenges of advances in genomics.
Great, thank you. And we will be back.
Okay.
Professor Yearby, thank you so much for being here in from Columbus, where you're a professor of law at Ohio State University. Can I also ask you to share a little bit about your work and research focus, including health justice work and how it relates here?
Yes, so good morning, good afternoon, everyone. I am Professor Yearby, and my work is really built on my undergrad degree in biology, combined with public health, law, bioethics. And so what I try to do is bridge the gap of all those different disciplines to talk about the ways that oftentimes we misuse biology, science, law, public health to replicate and reinforce racism, discrimination against a whole host of people. So I'm excited for this conversation. And just a little bit of background. So some of my work has been as a member of the U.S. Department of Health and Human Services Secretary Advisory Committee for Human Research Protections. And so I will not be speaking as a member of that, but that informs my view sometimes of the Common Rule and the Belmont Report, which we're going to talk about a little bit.
Yeah, so if you don't know Belmont Report, if you don't know the Common Rule, you will in less than an hour. Okay, so I think one of the first things that we need to do is do some term definition to make sure that everyone here and on Zoom is on the same page. The first part of the title of this panel is AI. So I want to give folks just how I'm thinking about AI. I'll ask you, Professor Callier, to add some color about how genomics plays into this and how we might differentiate from simple genetic samples and actual data sets. But our running definition for this afternoon's conversation is going to couch AI in the processing of large amounts of data. That is going to include pattern recognition, components of decision making, and that includes other language that you've probably heard before, like machine learning and the employment of algorithms. So it's about the ways that we can use large sets of data to crack into new spaces of knowledge. And the advent of quantum computing, I think, is going to fundamentally change some of the questions that we have to raise in this space. If you're not familiar, quantum computing is the ability to process information at a much higher pace and in larger amounts. And so for genomics data, that really matters. And we're going to talk about the definition of genomics if you're not clear what we're talking about there. But to get us started in terms of this defining of terms and how we should be thinking about this as we move forward, Professor Callier, can you tell us maybe a little bit about how we might think about samples rather than data and why that matters here?
Sure, absolutely. Whether we're talking about samples or data has governance implications. And so we're a room full of lawyers. So when we're talking throughout the afternoon or within the next hour, I won't keep you the whole afternoon, although I could. We want to make sure we are distinguishing between what is possible with a sample, which is finite. Think about a blood sample that you might give or a cheek swab that can be used to create a DNA sample that is used in a lab. And oftentimes that DNA sample may have a shelf life unless it's replicated like the immortal cell line that was replicated in the case of Henrietta Lacks's HeLa cells. So when you're thinking about governance, there are a lot of concerns about communities donating samples, what happens to the sample. We might have questions about who owns the sample. So when you go to a doctor's office and the doctor takes tissue during a routine visit, or maybe during a surgery, in some states, the doctor is actually required to throw that sample away because it's hazardous waste. In other cases, the doctor may use it for research purposes. And you might ask, well, do I have any ownership rights in that sample? Data is a little bit different because data is taken, when we're talking about genomic data, that's data that's taken from the sample. And that information in this day and age can be stored on a computer, it can be stored in a cloud, it can be shared easily. It's a lot easier to obtain and share data with anyone who has the means to download and view that data with broadband access, et cetera. But it's also harder to control data. And so when you're looking at a law, some laws might be specific to samples, others might govern data, and others might govern both. And so it's important to ask, okay, hold on, what are we talking about here? Are we talking about samples or are we talking about data?
Okay, great. Thank you so much. I want to raise one other question and see if either of you want to comment on the way we might think about something that I was talking about with my contract students Wednesday morning, which is this concept of garbage in, garbage out. Now, there's tons to talk about, but I don't think we can talk about AI, and especially like the idea of race, which we also need to unpack, and ethnic identity without talking about this concept of garbage in, garbage out. And I wonder if either of you have thoughts there.
Sure, I can start. And we see this in genetics and we see this with AI and machine learning and data science. It's this idea that consider a reference data set, a place where the data is going to come from, that a machine is going to study and learn, that is going to be used for artificial intelligence, or that is going to be used to predict disease or the probability of an illness in the case of genetics, or some other health outcome or behavior in the evaluation
of a treatment, right?
Or the evaluation of a treatment in the case of data science. What is in that original data set is going to, and how it's defined, the terms that you use are going to impact the quality of the results or the outcome that you're seeking through your technology.
Okay, helpful.
Yeah, and I just wanted to go back to something we talked about before this presentation is we have to think about what is the data going in. And we haven't thoroughly defined it appropriately or gotten rid of our biases. And so that is information that then is going in. And right, so when we think about perhaps you sending your information, your genetic information to a corporation, 23andMe, or universities using that, and then they give you data back, it's not always as scientifically sound as it should be. And what do I mean? Is that they're oftentimes using your genetic data to say, oh, we think that you have some ancestry that is Japanese or that is from the Vikings, but that's just based on the information they have. That doesn't mean that that's all the information there is, right? It's based on who has decided to give their information, and then they're making assumptions that that is all there is. And so what does that mean? Because that was really high kind of theoretical, right? It's this assumption that based on the individuals who are giving genetic data, which are traditionally white individuals trying to expand their understanding of their ancestry, that we are basing your ancestry on that data set, which is not full. And so then we are creating this thought that we actually understand what true ancestry is. And now we're going to give that to a computer to be able to identify and say, oh, ipso facto, it is scientific. Right. And so I know we're going to talk about it a little bit later, but we haven't even done all the things we need to ensure that our science is sound. And now we are building models off of that. And so then we are just going to replicate that garbage.
It's a question of credibility, right? And about what we trust. So thank you for that. There's way more to say there, but I'm going to move us on. Because I also put in the title this language, African diaspora. And I want to talk about that. And I want to talk about something that we talked about on our call and spent a lot of time, and that I think it's really important for this group to walk away thinking about.
Yeah.
And that is the conflation of the idea of diaspora with race. So I will first turn to Professor Yearby and then Professor Callier, but I think this is a really important component of this conversation.
Yeah, I think it's hard to define it. I know we talked about this, right? In the sense of who is in this group and who is having the power to decide what that is. We traditionally think about it in terms of Black individuals who are in the US, also individuals in the Caribbean. Maybe we include some people who are in South America and Mexico. We include some people who are in Africa, but as many people don't understand, it's not all of Africa because part of Africa is cut off and not included in this discussion. For me, I think it is more about a broader context about who has power and who is valued. Really, people coming together to talk about that in terms of experiencing colonialism, imperialism, capitalism, but it's not a clear definition. And oftentimes we try to use race as a proxy, which we'll talk about a little bit later, is not a good proxy because there really is no genetic basis for race, and our social definitions are not as clear either. Because if you listen to our definitions here in the US, nobody understands them because they don't make sense. And the definition of who is Black in France is very different than who is Black here, but there's still racism. And that's not even captured in all of this discussion. So I'll stop there and pass it.
Sure, I'll just give an example. If we look at the way racial categories have changed over time, to your
Can I
point.
give you a quick shout out before you start?
Sure.
I just want to say that Professor Callier is coming from a conference on data science on the continent. And has a really specific lens through which to help us think about this question. So I just had to, she went out of her way to be here after flying across the ocean. And so I just wanted to also add that lens to the work that you do.
Thank you, and it's my pleasure to be here. I would not have missed a conversation on genomics and AI in the African diaspora. It's a real pleasure to have this conversation, and I'm looking forward to the questions from the audience. But what I was going to say to Professor Yearby's point about power dynamics. If we look at the census and how it's changed over the years, we remember that there was a time when the census was really focused on keeping people in their place and understanding hierarchy in a society. And so you were free, you were white, free white, you were enslaved Black, right? So these notions were very political. But over time, we've attempted to begin to use race as a way to correct for injustices and to help society advance civil rights laws or fair housing laws. And so we started collecting, we've changed the categories many times, and we've started collecting racial information as a way to see if our fair housing laws are working or who's violating them. And so there's a very political undertone to it, but that's just one way of looking at terms like African diaspora or Black, white, Asian, or even the genetics field. The genetics community often uses the term African ancestry. Scientists will say, I'm studying an African ancestry population, or I'm studying a European ancestry population. And so these are terms that scientists are using in a way to describe what is ultimately supposed to be scientific. But as Professor Yearby said, there's no biological basis. We cannot look at a person's skin tone and know their underlying genomics. And so while we might use the term African diaspora in one context because it makes sense socially or culturally, or you're seeking maybe to connect with people from overseas who share some ancestry from the African continent, it does not, we run into problems when we begin to use such a broad continental term when we're asking scientific questions. And the consensus in the scientific community is building around the idea of moving away from continental labels to describe populations for that reason.
And I just want to add one thing. And as you were mentioning, right, we use African ancestry, European ancestry, but we do not require people to define what they mean. And that is a problem, that we use these terms and then expect everything else that follows to be scientific and clear, but don't start with the terms being scientific and clear, which causes a lot of issues. So I just wanted to.
I think that's excellent. Go ahead.
May I give an example?
Absolutely, that's what I was going to ask you.
Medical implication.
Yeah, absolutely.
So for example, and I talk about, this example has been around a while. There is a drug called abacavir that treats HIV. And when abacavir first came on the market, researchers realized that patients who identified as European ancestry were likely to have an adverse reaction to the drug. There was a prevalence of a gene in white patients where they were likely to have a bad reaction, and a bad reaction to abacavir could be fatal. So the FDA made recommendations that there be genetic screening of people of European ancestry before prescribing the drug. A group of scientists went back to international data and looked at the prevalence of the genetic variations that cause a poor reaction and possibly deadly reaction to abacavir in different population groups. And some of the findings were really interesting. For example, among the Luhya in Kenya, there was a different prevalence of the variation than the Maasai in Kenya, two neighboring ethnic or tribal groups. Among the Yearby in Nigeria, there was a completely different, wildly different variation from one of the tribes in Kenya. And so using the term Black or African ancestry in that case can have medical implications because the doctor would not necessarily know how he or she or they should go about prescribing a drug to a patient that looks Black in front of them. And so after this research came out, the FDA and others recommended that everyone be screened for this genetic allele because we cannot base it on these racial categories.
Excellent, right? You really have to break down the continent and the populations within the continent. We know it was carved up, right, during colonial periods, not based on community or populations, but by political power, which you've already referenced, this idea of power, right? And then we have the closer to home example of Vital, right? These are the ways that we can see the use of race and amalgamation of populations as a marketing tool. And I wonder if any of y'all would like to speak to the example of Vital or maybe give folks some more color.
Yeah.
No puns.
And I almost want to kick it back to you
Okay.
to start. Why don't you
Yeah,
start?
so-
Yeah.
So Bidil was a drug that was for I believe cholesterol, or heart failure. And they found that it was effective only in a sliver. And this was a pharmaceutical company. They wanted to make as much money as possible. And so their reaction was to say, let's get Bidil in place as a treatment for Black people with heart disease. Lots of problems there. We had a short discussion yesterday and you talked about the patent questions that accompany that.
Yes.
So that is one of the ways that I think it's worrisome to think about both garbage in and garbage out is deeply connected to this definition of diaspora and of who is Black. And that actually infers and connects to treatment decisions when we're seeing AI really explode in healthcare as a mechanism to control cost often.
Yes, and just to give you a background, and so the Bidil was a combination of two medications. They were running out of their patent. They figured if they put it together, they could extend their patent. They did research. They got rejected, but were able to go back and pull out this sliver of how it showed improvement in Black patients. But it was such a small group, and then use that to then go in and say, oh, we're trying to help Black people. And so let's get the support and be able to say this is a drug that reinforces the notion of race. But at the same time, doctors were still off-label prescribing it to white patients because it's just a combination of heart failure medication, right? And so it's this tension, again, of being aware sometimes how companies can misuse this thought of health equity and this thought of race to improve things when their overall goal is just to make money and reinforce this notion of who is Black and at a biological level, which again is not true. I think that's the hardest part for us to wrap our heads around is that they're, and I'm going to say this, and you definitely disagree with me, but there is no biological link to race. Right? Skin color doesn't even work because Black people don't all have the same skin color. White people don't all have the same skin color. And it's not just Black and white people, right? And so when we think about biology, I really want people to stop saying race is biological. It's not even really social, because we can't define who is Black. It is a one-drop rule. It is sort of what you perceive, what you say, who you are, right? And so it's not really helpful in this context.
It's the medicalization, right?
It is
and the idea of, it makes you also think of like blood quantum, but for Black folks specifically, there's a medicalization.
Yes.
Professor Callier.
Sure, there's so much to unpack here. I really don't know where to start. I think I'll start with the case of Bidil because it's a really great example of the complexity of market forces and the challenges of race-based health inequities in society and people actually wanting to do good and help patients. The doctors who did the study on Bidil, they aren't bad people. They want to reduce health inequities. They want to serve Black populations and other patient populations, but their primary goal in encouraging the FDA to approve Bidil was so that they could help eliminate the health disparities that come with heart failure in this country. So I don't want us to walk away thinking that these were bad people who were promoting the drugs. Lots of Black people and grassroots organizations and clinicians who see patients die from heart failure every day promoted this drug. There were tons of complexities and problems with the clinical trial. You could read the work of law professor Jonathan Kahn, who's written a great deal about it, as well as Dorothy Roberts, a law professor at UPenn, who's wrote about Bidil in her books. But you know, it's too complex even. Sometimes I spend 30 minutes just talking about the Bidil trial alone. But what it does highlight is that there are camp clinicians. The debate on race and genetics is it's very real, it's ongoing, and there are experts on both sides who disagree. I do not believe race is biological. I just want to clarify that, since you said I might disagree with you. No, I agree with you. Race isn't biological. If President Barack Obama went into a clinic, a doctor would treat him as Black and possibly believe that he's West African ancestry, when his ancestry that he identifies with is from Ireland and East Africa. Same thing with Kamala Harris, who might come into a doctor's office and be treated as Black, and the doctors may not take into account her Asian ancestry. And so we are all from different ancestries. We all may have 4 ancestries, 5 ancestries, maybe even more. My colleagues at NHGRI identified 282 different ancestries around the globe and said the norm is for a human being to have a heterogeneous ancestry. And a person in Africa is more likely to be genetically similar to someone living in Europe than he is going to be genetically similar to someone right next door. So you get back to Bidal and you say, well, what does this mean for a drug in the United States that's been designed to help treat heart failure? Now, there were problems with the trial. They did go back into the data to try to get it onto the market. Someone did want to make money off of Bidal. That's why they did an African-American heart failure trial as well. But we're looking at African-American patients who identify as African-American. It was a self-identified group who live in the United States, who are part of this group that's suffering health disparities. And when they placed when they did the trial, I think it was something like over 40% reduction in mortality rate. And that was deemed to be so high that the trial was stopped because it was considered unethical to keep giving patients the alternative. And so that's how it ended up being the first FDA-approved drug. It was approved in 2005. My problem with Bidal is that today in 2023, we still do not know the genetic basis as to why 40% of people responded well to the drug. Where is the research on the biological mechanisms that go beyond race? Where are our priorities in identifying the biological mechanisms that go beyond race to help us understand what makes a person respond to a drug? Doctors today, many argue that because we still don't understand the underlying genetic basis and ancestries that lead to genetics of drug response, that we have to rely on race. It's an argument that's often made that we don't understand ancestry enough in the clinic for ancestry and genetics to have a clinical impact. And that goes back to the garbage in, garbage out problem. We're not producing the data that we need so that we can use genetic data effectively in the clinic. And so you have a camp of doctors who are saying, for this reason, race is the best thing that we have. And then we have others who completely disagree and say that race is not a proxy for biology, and that there are plenty of patients who don't identify as Black who might do well on this drug and then they won't receive it, or will begin to offer patients this drug when we should offer them something else. There are plenty of physicians who disagree. But my problem with all of this is, why in 2023 are we still having this debate? Where is the work to help and the inclusion and the high quality data to get us to a point where we can use the tools that we have to better diagnose and treat populations?
Thank you.
Yes, and I want to jump in.
I'm going to push us on.
Yes. And no, I didn't think you thought race was biological, but I knew you would have a more nuanced discussion of Bidal, which I appreciate. And the other thing that I want to say is, what is interesting to me is that we allow people in science to say we cannot find anything else to use in place of race, but want to jump on to AI and quantum computing and all this other scientific things. We have the money, the time, and the space to do it. And I don't understand why we know that race is not a good proxy, but we won't spend the money or do the research to actually go to the genetic level and figure out that level, the environment, and all the things that are really the key, right? We can be lazy on one aspect, because we don't have enough time, we don't have enough money, but then we use all this money to go forward, and it's just gonna replicate the garbage. Yes.
Okay, this is all excellent, right? This is the point of the complexity of definitions, which for law students is really critical. And the lack thereof within science is something for us to really ponder when we just have created, put science on a perch in which we simply trust it and don't ask more questions. Thank you so much for complicating the Bible story. And thank you so much for those comments. I want to touch briefly on genomics because it's different from genetics and I want to make sure everyone's on the same page. So the difference based from the WHO is that the difference is that genetics scrutinizes functioning and composition of the single gene. Genomics is actually trying to understand all of these interactions, how environment interacts. There's a concept called weathering, which is a quite strong hypothesis with respect to Black maternal mortality, which thinks about this interaction and the way that it presents, right? What gets turned on and what gets turned off. And because the genome is so large, you need to think about quantum computing and genomics to try to get your hands around it. But I want to also open that up just for a few minutes because I want to make sure we get time for questions. And there's one other thing we need to talk about. But would you all like to say anything briefly, I'll say, about how we can think about genomics and why it matters in this discourse?
I'll let you say.
Sure. So genetics, we're thinking about single gene mutations like sickle cell trait, which I think we'll talk about if we have time, cystic fibrosis, and rare diseases. But with genomics, we're now able to start thinking more about cancer and diabetes and really complex diseases. And so one of the reasons I'm engaging in this work is because I think it's important for us to understand the genomic basis for diseases for all people, regardless of what continent your ancestors come from. And I want to see us reach a place where we can use genomic information to help cure complex diseases. But as we were discussing earlier, and I think we'll talk more about this, the data that goes into genomic studies is limited. Most of the work, the genomic research is based on limited data sets that come out of Europe. So we know a lot about European ancestry populations. There are very few publications and data coming out about Native American populations, African ancestry, or people with ancestry from Africa. See, even sometimes I use the phrase, the data is not enough, and that has clinical implications for our research. And so it's important, it needs to be more diverse. And not only that, we need to study once we recruit people from diverse populations, we need to study the data and we need the tools, we need the algorithmic tools, we need the artificial intelligence, and we need the genome sequencing tools that are capable of understanding genomes from diverse populations.
And I will just jump in. I think coming back to weathering and sickle cell, I think it's hard because even in those instances, we are reinforcing this notion of race. And so sickle cell is often spoken about as a Black disease. That's because historically, the first few people who had it were mixed race, and the doctor said, well, it's the Black part that is causing the disease. And you can look this up. They said that. And so it is not a race-based disease. It is a disease that gives protection for people who are in malaria zones, right? That includes Afghanistan and Greece and all these places that we don't think of Black people being, right? And I want to say weathering. I love the thought about weathering, but again, it is tied to race. And it really reinforces this notion that there are inferior races. Now, definitely African-American women who are born and raised in the US tend to have poor birth outcomes. It's because of racism, because when Black Caribbean women were tracked in terms of their birth outcomes, they were the same as white women. The longer they stayed in the US, their birth outcomes became worse. That is not genetics. And what I think the problem for me is with weathering is that we always do a comparison between Black and white.
Who's the default?
Instead of doing US and other places that are much healthier, because then what you do is you hide the poor mortality, the infant and maternal mortality for whites and Asians. And guess what? If you look at the data, whites don't even have the best maternal rates or infant rates. It's Asians. But again, that's too broad because Asians is too broad. And so what my hope is that as we're trying to battle these health disparities, that we don't reinforce some of this discussion in some of the data. But it's hard because we have been trained based off of that. And we want to help people, just like you said, the doctors of Biodale, but how do you do that if you are not tracking race in a scientific way? You have to separate out the racism and oppression that people face. And I don't know, it's really complex. We're not going to solve it today, but we want you to think about those things.
Quickly.
And
Okay.
I want to add to that too, because the categories that we use to describe people around the world are limited. The researchers, because we've collected so much data using limited categories, so maybe we only have data from the Yearby in Africa, and then we always refer to that data set and study that data set even, or we may, even though there are other populations that are surrounding the Yearby that we have not studied, and we don't have genetic samples. We just don't have enough genetics information. We just don't have enough data. And so what I'm excited about to build on Professor Yearby's point is that we are in the age of data science. So now I'm not just looking at your zip code, because really zip code is going to be a greater predictor than just race alone, right? Are you from Mississippi or are you from Washington State? Now I can learn about your geography. I can learn about your health habits. I can blend in, while there are privacy risks and more risks that we could talk about, the promise is that I can use real world data about your life and your environment and couple that with what I know about your biology. I should no longer be just saying black or white. I should have a characterization based on all of the data I have available to me, and should be able to make predictions based on who is in a similarly situated.
Yes.
And that will advance what we can do in genomics through data science.
Yes, thank you. And just, I want to clarify on weathering, right? Because I think when I was using the term, I really was folding it back into genomics and thinking about how race, right? Because the idea of weathering is that living a certain kind of life has impacts on health outcomes. And so thank you for the clarification, but certainly wasn't trying to reduce it to race. But
You not. I'm speaking generally, because
Okay,
when people talk about weathering, and I have had the opportunity to be on calls with airline directors who came up with it, it's always this tension of what we're trying to show. And yes, right. And not just being reductive, is that we have this language and it hasn't expanded in the ways that we need it to. And so when we're trying to fix the problem, sometimes we can't find the language to get to that. So it wasn't particularly to you. It was just generally about the work that we still need to do, that hopefully you will do, right, as you are in this space. And I'm going to move us on, but add something too, hopefully, because I'm talking a little bit much, but I wanted to build on what you were saying, is that we need data, but we need protections and we need privacy, and who owns the data?
This is a big question. This is the question that I think we're hoping to leave you with here. I hope we can get, I want to talk very briefly, and maybe we'll kind of cut this off and I'll just give folks some background so we can get to kind of the quote unquote the fun part. Because we've been building, but now, like, what does that larger conversation look like? So I just want to talk for a brief moment on research regulation, but feel free to bring it back when we get to this first question. And I want to raise two things for you to think about. One is the Belmont report. This occurred in the late 1970s after discovery of the Tuskegee syphilis study, which was carried out by the U.S. Public Health Service. And because it got public outrage going, the government said we need to do something. That Belmont report created a series of principles to guide human research regulation in the United States. I'll also note that the US, following World War II, was really stringent about Western Europe, Germany, those countries creating strong policies to ensure research participants were protected, but did not create them here, which is a fascinating component. The Belmont report occurs, and then the common rule follows it, which operationalizes it in US regulation. That is how we create oversight mechanisms for human subjects regulation. We have a conversation around how much we like the structure of the common rule and how much it does for the people who actually were carrying the burdens of research. And we can talk about that some more. But if I pull us back to do the fun part in theory, there's a really fundamental question for me I think about cases that R1Ls haven't done yet, but like Moorby Regents. And these questions, which is a case in which a man has a very specific type of cancer and UCLA tricks him, I think we can say, into traveling multiple times so they can do research. And they make billions of dollars off of the patent related to that research. That leads me to this fundamental question when we take this, both the problems and the promise. How do we think about who benefits? What should we be concerned about? And I think I'll give that to y'all, and hopefully we'll have time to go to the audience for some questions.
Well, the common rule says that no one population should suffer the burdens of research unduly in an unduly way, and that the benefits of research should benefit the populations that are included, science or society. There's autonomy, beneficence. Well, respect for persons, beneficence, and justice are outlined in the Belmont Report and codified in the Common Rule. But for the past, I don't know how many years since it was passed in 1974, we focus so much and deservedly on informed consent and autonomy. But as we enter this age of genomics and data science, it is time now. It was time before, but if anyone wants to ask me about my opinion on ethics before the Common Rule was published, I'd be happy to give it. But it's definitely time now as we think about data science and genomics to include respect for individuals and informed consent, but to also start thinking about communities. And this question about who benefits and who's harmed is going to be critical due to the capabilities of data science and the capability for good as well as the capability for harm. And we have seen some cases that have settled out of court that have highlighted the gaps in the Common Rule when it comes to protecting communities. One that comes to mind involves the Havasupai tribe of Arizona, and that settled, so it didn't become law, but it raised awareness that we have to start thinking about benefits to communities as well.
And the Havasupai were a Native American population that were, I think, easily we can say manipulated by a researcher. Go ahead.
Well, the broad consent was used in that case, which is to some is vague, and there's a debate and controversy around the use of broad consent. But I think that case highlighted for us what broad consent can mean for certain communities, that they may not really understand the future uses, and that can create a problem that can lead to community harm.
And I think too, it makes me think of a chapter from Harriet Washington's Medical Apartheid, of the study of kids in Harlem around violence and genetic predisposition. And so the ways that when we use this terminology or use Blackness in place of, that we get to further reiterate narratives that we have decided define a people.
And there's so much. I'm going to keep it focused. So what I would say about the Belmont Report, why it's great, is that it was one of the first opportunities for justice to be brought into our discussion about research. When they translated it to the Common Rule, they reduced it to really talking about equitable selection of research of participants. Thank you for that. But to me, justice is the place in the Belmont Report where we're talking about communities, because you see the language of them talking about communities. But we need to do a better job of implementing that into our research industrial complex. Now, part of the issue with these things is that the research questions are not sound, right? And so what you were reflecting on with Harriet Washington's book is that they decided to do a trial around criminality, and guess who they used? Latino and Black people. That's who they used. And so what are we really talking about here again? The only other thing I would say is going back.
Can I just add something to that story, right? That person is still researching at Columbia University.
Yes. And so I want to pull in two more points and then I will stop. Is that one, I think we need to expand this view. Today, we're just talking about race, but the Belmont Report was because of Tuskegee and Willowbrook, which is a study on those who were disabled as well, right? And so this is a broader context and there are intersections there. But when we talk about benefits and who owns the data, what is clear to me is is that researchers, research companies, and university cannot be the only people who own the data. And that was part of the issue too with the tribes, is that we own the data, will allow you to use it, but we still want to own the data. And the last part about the benefit is it can't just be about us gaining access to the drugs, to whatever they're creating. It has to be that we get part of the profits. And I'm gonna say that again, we get access to part of the profits. And that means like, I don't need it going into my bank account, even though that would be nice. I need it going into my communities, right? Because that's the whole point, is that you are taking money out and supposed to do these great things, but drugs are not gonna fix the environment, right? And so part of it needs to be a redistribution of this money into places so that we can begin to fix it, which I know is different, but I'm gonna stop.
I don't think it's different. I think it's part and parcel. I mean, I think about the work of Sandy Darity, who is writes a lot about reparations and talks about the idea that it's not a check to each Black person, but it's actually structural reform and how we pour money into that. Professor Callier, you're just back from the continent.
Yes.
Can you talk to us around the perhaps what you would view as like the paradigms of data ownership and genetic information ownership? Are there contrasts? Are there lessons for us to learn?
Well, there are certainly very few laws among African countries. There are very few countries that have very clear laws related to ownership.
Okay.
There are laws about samples leaving the country or samples being used for research. Some countries have laws about samples, some about data, some about both. There are a few countries that want to experience benefit before a sample leaves the country. Investigators who are external have to explain how they're going to benefit that community. And I think that this idea of negotiating benefits is a really important one as we move into the next era of genomics and data science. Is going to be important for us, for the communities that are marginalized in the United States, and it's going to be incredibly important for the communities that are in Africa. So for so long, many of you have probably heard the term helicopter research. For so many years, researchers from rich institutions have gone into African countries, taken genetic samples and left, never to return the samples, never to return results, never to benefit African communities in the countries where they've done the research. And that's been called a lot of things. One of the names is helicopter research. And so we're entering an age now where there's more of a discussion of, if you're going to come in and engage in researchers locally, what are some things that you can provide to benefit? And one of the benefits could be capacity building. So there's a great consortium called Human Heredity and Health in Africa. And it's a consortium funded by NIH and the Wellcome Trust. It funds investigators in Africa. You must be an African scientist to have benefited from it. The program ended and it's transitioned into data science, but it lasted for 10 years. And there were rules developed by ethics committees, laws and rules and policies, more guidelines and policies. And one of them was that African researchers were not just data collectors, but they had an embargo so that they could publish their results first. So we're starting to look at these models. What kind of model can be created? If it's not a check in our bank accounts, we all would like that. What are some other things? I love the idea. There's an article that came out recently about Mexican genomics capacity building, where scientists are actually from the Western or richer countries are training the scientists that they're working with and helping them to build capacity to do the research themselves. Now that's not, in the end, we're going to need more. I think we have private companies on our outline. I don't know if we'll get to that, but
there's a
what
lot
can
there.
Private companies do to help hire, invest, and build capacity so that we can have scientists from around the world who are trained to do this research? Because ultimately, if you're from a small community that's suffering from an ailment, you're going to be the one who asks those questions that are relevant to your community. Not even me all the way in Washington, D.C.
And
right?
I'm going to jump in because I want to try to get at least one question.
Yes, of course.
But I also would just raise for folks who are not familiar with this concept of community-based participatory research, which actually has community members actually starting to control the process of science and what comes out. But I also love that you raised for us corporation or private entity as maybe a lever to do good and not simply as extractive? And what do those third-party relationships look like?
Can I add one thing? It'll be 1 minute, less. So part of my research is to pull that community-based participatory research into the biomedical research and require that. And the last thing I would say is that we say that research is a common good, but then we don't clearly define what the common good for our communities and for our world is. And we need to start doing that. And it can't just be we get the new drug that we have to pay thousands of dollars or millions of dollars for.
If we have access to healthcare. Questions from the audience? Sir.
Thank you for your time today. You very clearly established the problems with self-identification, which everyone faces for any medical treatment that you receive or whatever form you fill out. That's always going to be a question. But if you're able to get a large enough research population to get sort of these underlying data, how do you balance that with then people's privacy rights? And especially in this day of like data privacy being such a big issue, people's privacy and not being genetically screened, not being put into a subset that may then have adverse effects on them for a different decision down the road.
So the law has traditionally, as the common rule, for example, and HIPAA as well, has traditionally de-identified data as a way to maintain privacy. So you look at a particular group of people, you engage them in a research study, you de-identify all of their data so that it's not connected to their name, their birthplace. And the common rule and HIPAA have different rules. The HIPAA rules are stronger. And then the research is no longer classic human subjects research because it's believed that those identities and the privacy is protected. Now that protects individual privacy. It does not stop someone from stigmatizing a group or discriminating against a group. And also, I don't know if many of you have heard, but for those who are using 23andMe and genealogy services, it's been predicted that at least 60% of the population are identifiable if you're of European ancestry because you have a cousin or a family member who's used 23andMe. And so the more genomic data is shared, the more data is shared as part of the data science realm, it is going to be harder to promise and guarantee anonymity. Some people say anonymity doesn't exist. So what we have to look toward then are governance mechanisms. For example, a company may have a contract with a hospital, and in that contract, there may be a line where the company says it will not re-identify any of the participants in the research study. Data use agreements as a result of HIPAA may have lines about not re-identifying. And so we'll have to come up with new structures to discourage any behavior on the part of companies that could lead to re-identification. But it will be difficult because consumers, a young boy found his sperm donor.
I was going to say that
just using genealogical websites for forensics. Law enforcement is able to re-identify people using these various lawsuits. So it's a very complex, tough question, but I hope I provided some background on some ways the law is trying to prevent re-identification.
Yeah, and I mean, you hit the nail on the head. I'll shoot it to you and you'll have our last word before I thank you, because I think we're about there. But the idea that de-identification is possible is quickly becoming, to your point, perhaps not a reality. We need to figure out how to manage that.
New ways of governing and protecting individuals and populations.
Yeah. And I think it's also because we focus on it in a particular aspect of potential research, but not on every aspect, right? And we worry about it in that aspect of going to your doctor, but then we send it out, or people send it out in our families to these corporations, and they don't have the same protections. So we need to revise the system to be more protective, but then get more data from you within the clinical setting that hopefully we can use to better serve you. I do want to mention GINA, genetic
Information Non-Disclosure Act.
Right, which is supposed to provide some protections, but does not fully. And so we need to beef that up.
And only for insurance, and only in specific. So we have this kind of patchwork of like privacy protections, but not something that's harmonized and that flows through. So thank you so much. I'm sorry we're out of time, but a huge thank you to the panelists. Thank you so much for joining us. Thank you so much for joining us here and on Zoom, and we will see you next time.